Hello, my name is Lon Dowell. I am the Global Director for IRIDEX's Retina business. Today, we're in Barcelona, Spain, along with 5,000 registrants to attend the 2017 Euretina meeting. While here in this beautiful and historic city, we have sponsored an educational symposium hosted by world-renowned retina specialists that have presented several cases based on our tissue-sparing MicroPulse technology. Please join me in viewing our recap of this exciting event and make sure to join IRIDEX at the 2017 ESCRS meeting in Lisbon, where we will present an educational symposium on MicroPulse transscleral cyclophotocoagulation. And to stay up to date, please visit iridex.com and be sure to follow us on all social media.
So good morning to everyone. Buenos dias. Thank you for coming. And thank you to IRIDEX for organizing this meeting. And most of all, thank you to our esteemed presenters who are here and who comes from distant places. So we have the pleasure to have Professor Marco Zarbin, who is the chair of the Institute of Ophthalmology and Visual Science at the University of New Jersey. And we have Dr. Munir Eskab, who is a vitreoretinal surgeon and who is using a lot of MicroPulse laser, and he's from Colombia. Okay, so we will start immediately this session on the use of the MicroPulse IRIDEX laser in vascular macular diseases. And the first presentation will be by Professor Marco Zarbin on the science, benefits, and utility of MicroPulse technology. Please, Marco, come.
So I thought I would begin by just showing you very quickly a patient who was referred to me who had had central serous retinopathy for more than 6 months and diffuse leakage of the RPE. And I treated him with MicroPulse laser, and literally 1 month later, the fluid was gone. So this is to just prove to you that MicroPulse actually does work. And if you need to convince yourself in your own practice, I think central serous patients are really the perfect cases to begin with because they respond so rapidly. What I'd like to talk about is how MicroPulse operates and in principle how it might work biologically. So the idea of the MicroPulse is rather than giving a continuous delivery of energy, the energy is delivered into short bursts. And you can see on on your left, with continuous conventional laser, the energy is delivered for the entire time that you are activating the laser. Whereas in MicroPulse, it's just a short burst of energy delivery. And in this example, of the 2 milliseconds of the delivery time, what would we call a period, you're actually delivering energy for 0.1 milliseconds. And that leads to the very important concept called the duty cycle. The duty cycle refers to the period of time you're actually delivering energy divided by the total pulse interval. In this case, it's a 5% duty cycle, and I think that in general you'll find the safest duty cycle is 5%, and you'll see a little bit of data that suggests that that's true in a few minutes. If you were to plot on the y-axis the temperature of the target tissue as a function of time on the x-axis with continuous laser, let's see if I have an arrow. Is there a pointer? So this is a pointer. Oh, so it should work. Oh, yeah, here we are. Thank you. So you can see with a continuous laser, the temperature is just continuously increasing, which means the heat is radiating from the target tissue, which has the chromophore, so that's the RPE cells, all the way into the retina. And of course, once the temperature is increased by 10 degrees Celsius, you coagulate the tissue and precipitate proteins. So what the MicroPulse does is it chops the energy delivery into little intervals. And in the 15% duty cycle, as you continuously deliver pulses, you see a gradual increase in the temperature of the target tissue. But as you decrease the duty cycle, you actually eliminate that gradual increase in the temperature of the target tissue. And you also confine the area of temperature elevation to a smaller and smaller distance. Ultimately, our goal with MicroPulse is to confine the energy delivery to the retinal pigment epithelial cells. So this is how it reduces thermal buildup, and this is how MicroPulse reduces collateral damage to the retina. Now there's a kind of interesting laboratory experiment done by Dr. Inagaki where she grew ARPE19 cells, retinal pigment epithelial cells that are human but not normal, in a culture dish in a monolayer. And she used the MicroPulse laser at different powers and for different durations of laser exposure. So in her case, she used a 15% duty cycle. And I'm showing you this picture to show you that if you don't use the MicroPulse laser correctly, you can make it act like a conventional laser. So let's see how that works. If you're working at a laser power of 600 milliwatts and you have a 1,000 millisecond exposure, you can see that you are coagulating RPE cells. And of course, if you go to the higher power, you're doing even a bigger coagulation spot. But if you decrease the exposure all the way down to 500 milliseconds, then you don't see any spot at all. And that, which you can see clinically, I guess you could say, on the left, is illustrated graphically on the right, which is that for every given power, as you decrease the duration of laser exposure, you decrease the coagulation damage to the target tissue. So decreasing the duration decreases the coagulation area. Now, you might be tempted to think that a subthreshold continuous wavelength laser spot would be the equivalent to a micropulse laser spot, and it is not. And that's, we could argue about that theoretically, and I have actually seen people argue about it theoretically, but there's no substitute for looking at a clinical picture. And this is a barely visible patterned spot, and what you can see is that there's damage to the retinal pigment epithelium, and these white columns represent damage to the retina with retinal edema. And in contrast, working at the same energy delivery with a micropulse, you see absolutely no change in the OCT of the target tissue. How does micropulse work? Well, it isn't that it doesn't damage the tissue, it's that it doesn't kill it. And I think that's an important distinction. So the target tissue is the retinal pigment epithelium. Now, if you use a conventional laser spot, so this is a schematic drawing of a conventional laser spot, what you'll see is necrosis of tissue in the center of the spot, and at the perimeter of the spot you see a tissue that's damaged but not dead and not destined to die either. And it's that tissue, in the case of the conventional laser, that produces the biological molecules that have the therapeutic effect of the laser. What are those molecules? Well, heat shock protein 70, which protects cells from apoptosis and is anti-inflammatory. Pigment epithelial-derived factor, which among other things is anti-angiogenic. Thrombospondin 1, which is anti-angiogenic. Stromal cell-derived factor 1, which recruits bone marrow-derived reparative cells. And beta-actin, which is important for the reorganization of the RP cells after they recover from the injury. The difference between the conventional laser, which is shown on the left, and the micropulse laser, which is shown on the right, is simply that there's no central area of necrosis. So everywhere you're treating turns into a little factory, you could say, that produces these molecules that have a therapeutic benefit for the retina. Now this is actually back to Dr. Inagaki's laboratory experiment where she's showing pictures of what these laser spots look like. And there's a stain you can use to stain dead cells, and it makes the dead cells look red. And there's a stain you can use to stain the LOLV cells, which are the green cells. So on the left column, you see the continuous wavelength events, and on the right column, the micropulse wavelength events. And you can see in the center of the continuous wavelength spot, there's a lot of dead cells. And in contrast, there aren't any dead cells in the micropulse spot. So there is a biological effect on the cells. And you can see the same thing in the phase contrast images. But I think the key picture here is the bottom one. At the perimeter of the conventional laser spot, the residual viable RPE cells are producing heat shock protein 70. But in contrast, in the micropulse spot, all the cells virtually are producing it. So that's a pretty clear illustration of the biological difference in the effect of conventional versus micropulse laser. Now, a very important concept, I think, is the concept of the density of the spots. And for those of you who are of my generation or older, 60 years or older, we learned that if you're using conventional laser, it's better to use gentle applications of laser and not high-intensity burns. So high-intensity argon macular laser is an error. Pattern scanning or low density is right. Okay, that is not the case for micropulse laser. Micropulse laser doesn't really work very well if you use low-density spots. So if you're a person of my generation, you might be very reluctant to do high-density treatment, but in fact, it's high-density treatment that gives the greatest therapeutic benefit. And you don't need to worry about it because this is not killing the cells if you've done the procedure correctly. Now this slide shows the amount of heat shock protein on the y-axis as a function of time when you use 81 spots. And I'm showing it to show you that very shortly, 10 minutes after you do the treatment, you actually begin to see an increase in heat shock protein. But the peak level is at 3 hours, and then even at 24 hours, there's still continued production. This is a way of showing you that the micropulse laser initiates a cascade of biological events that take time to evolve. And that's why it takes longer to see the therapeutic benefit with micropulse than it does, say, with anti-VEGF injections. But the primary point of this slide is shown on the right, which is to compare the amount of heat shock protein after 81 spots versus 477 spots. And you can see that the more spots you have, the more heat shock protein is produced, which isn't surprising at all once you see the immunohistochemistry. Now, does this slide have any clinical relevance? I think it does, and that's illustrated by the small but randomized prospective double-blind study done by Dr. Levinsky, where he actually looked at the clinical outcomes treating patients with diabetic macular edema using conventional versus low density versus high density micropulse. And the micropulse high density treatment gave 12 letters of improvement, which, if you recall, is actually at least as good and maybe a little bit better than what's been observed for the registration trials for ranibizumab and aflibercept. In contrast, the low density, or what we could say normal density micropulse laser, gave very little visual improvement. And the conventional laser gave about 4 letters of improvement, which is actually very similar to what was observed in Protocol I. So high-density treatment really is the way to do it, but you have to have the right duty cycle and the right power. And those clinical decisions are going to be explained by the subsequent speakers. So areas where micropulse laser, I believe, has been shown to be effective in treating diabetic macular edema due to retinal vein occlusion, central serous retinopathy, as I showed you, juxtafoveal telangiectasia, radiation retinopathy, and also for glaucoma. It works on the same principle of the pigmented cells of the trabecular meshwork as it does for the retinal pigment epithelium. Thank you for your attention.
Thank you, Marco, for this excellent presentation and for showing us very clearly the science behind the use of the high-density treatment when we use the micropulse laser. So now I will talk to you about micropulse laser in diabetic macular edema, morphologic and functional safety and efficacy. So recently there is an increasing body of scientific evidence of the use of subthreshold micropulse laser in retinal diseases, especially diabetic retinopathy and diabetic macular edema, for sure, central serous chorioretinopathy, macular edema due to branch retinal vein occlusion, and so on. So in the era of the intravitreal injections, definitely the indications, the technique, and also the treatment algorithms of the use of laser have all been changed. But the laser treatment still exists in diabetic macular edema, and it has been largely proven by all the randomized clinical trials evaluating anti-VEGF treatments in diabetic macular edema, because they show that approximately half of the patients in the trials still need laser for persistent macular edema. So recently, a meta-analysis of the randomized clinical trials that evaluated and compared subthreshold micropulse laser versus conventional ETDRS laser in diabetic macular edema, evaluating approximately 400 eyes, of which approximately half were treated with subthreshold laser and half with conventional laser, showed that subthreshold laser gives better results in the term of visual acuity results when compared to the conventional laser, whereas there was no difference, significant difference, in the results of central retinal thickness changes after the treatment. So we all know that when we perform the standard ETDRS laser, we can all see the spots on the fundus where we perform the laser treatment. And it is clearly seen on almost any imaging modality we use for the evaluation of the retina. Whereas when we perform the subthreshold laser, we do not see any changes on the fundus. And how it is safe, recently, Jeff Luttrell and Stephen Sinclair published a paper where they performed subthreshold micropulse laser even in the fovea in mild center-involving diabetic macular edema in patients with good visual acuity, and they did not find any changes on fundus autofluorescence or fluorescein angiography after the treatment. Even more, subthreshold micropulse laser can increase a visual function when evaluated with microperimetry. So it can increase retinal sensitivity in the macular area, whereas standard ETDRS laser decreases retinal sensitivity. And this was evaluated in a, although small but randomized and prospective trial of the duration of 1 year. Here I can show you a case. This is a case treated with 810 nanometers micropulse laser, so with the infrared wavelength. You can see the patient before the treatment, 3 months after and 6 months after. You can see progressive decrease in hard exudates and increase in retinal sensitivity in the central area. Or another case treated with a 577 nanometer micropulse laser, so with the yellow wavelength. This is before the treatment, 6 months after the treatment, and you can clearly see that there are no signs on fundus imaging of the laser treatment, and you can see also increase in retinal sensitivity and decrease in retinal thickness. And when we evaluated and compared the two wavelengths in diabetic macular edema, using the predefined settings, so using the smallest duty cycle, it is 5% duty cycle, the small spot size, so 100 or 125 microns, and using similar power settings, we did not find any difference between the two treatments, and we find that both wavelengths are able to increase retinal sensitivity as soon as of 3 months after the treatment. We did not find any changes on fundus autofluorescence and no changes in the outer retina on spectral domain OCT, and no decrease but increase in retinal sensitivity. We also did not find any changes in choroidal thickness after the treatment. So we can say that the subthreshold micropulse laser, in order to be safe and effective treatment, you should use the lowest duty cycle, so 5%, small spot size. You should perform the high density treatment, and you can even perform multiple retreatments over the same area. It has been shown recently that it is more effective if you perform it in patients who have central retinal thickness up to 400 microns. And therefore, it can be indicated in those so-called mild center-involving diabetic macular edema, so looking at the retinal thickness cutoff, then in non-center-involving diabetic macular edema, but it can also be added to the intravitreal injections. So let's see some of the cases. This is the patient before the treatment, so you can see the center-involving diabetic macular edema. You can see visual acuity, 75 letters ETDRS. This is 3 months after the treatment, already progressive decrease in retinal thickness, and also increase in 5 letters in the ETDRS score. Here are the images of the same patients. You can see NFAS images on the OCT angiography, and you can see progressive decrease of the extension of the retinal cysts on these images. Another case, before treatment and after the treatment, just 3 months after the treatment, you can see the decrease in retinal cysts on these NFAS images. Or also this case, before the treatment, always center involving, mild, I would say, macular edema. You can see retinal thickness values, 79 letters, ETDRS score, visual acuity. This is 3 months after the treatment. You can see increase in 6 letters. So this is 20/20 visual acuity, and you can see progressive decrease in retinal thickness. So you can definitely do also multiple retreatments, as I said before, with this kind of laser. You need to know that you need some time in order this treatment to be fully effective. As Marco said before, it does not give immediate effect, but you need some time. And now we have also some long-term follow-up of these patients and long-term data. So I will show you some cases that I followed and treated at the University of Padua with Professor Midena. So this is the case before the treatment. This is 1 year after the treatment. And you can see an increase in retinal sensitivity as determined with microperimetry and resolution of edema. Another case, this is the case followed for 24 months. You can see these are multiple treatments, so 4 treatments. All these yellow arrows indicate the treatments, so 4 laser treatments. You can see also here progressive increase in retinal sensitivity over the time and decrease in macular edema. And another case also treated with 4 treatments and followed over 3 years for 36 months. You can see the progressive decrease in hard exudates. You see that it is not a rapid process, but it is quite slowly. But at the end, you see the results. You can see good values of retinal sensitivity and decrease in retinal thickness. So as I said, micropulse laser can be also added to intravitreal injections, so both after anti-VEGF or steroids, and also in order to eventually to decrease anti-VEGF injection burden, and it has been shown in a recent paper. I will show you this case of this very important center involving cystoid diabetic macular edema with subfoveal neuroretinal detachment that we consider has a very important inflammatory component. The patient was treated with the injection of steroids. This is 2 months after steroid treatment. You can see changes in visual acuity from 35 letters, ETDRS to 55 letters, significant decrease in retinal thickness. And then at this point, the patient was treated with a micropulse. And this is 3 months after the micropulse laser. You can see that retinal thickness continue to decrease. Here you can see all these stages of the same patient, before treatment, after steroids, and this is after subthreshold micropulse. So to confirm and to say again, in order to deliver a safe and effective treatment, you need to use the lowest duty cycle, the high density treatment. You can safely retreat the same areas. You should, in order to be effective treatment, you should consider the retinal thickness cutoff, as I showed you before, and also you need some time for retinal thickness to decrease. You cannot expect the results immediately. And I will just leave you with this slide that proposes what are the best candidates with diabetic macular edema for the treatment with the subthreshold laser. So you can see patients with good vision and extrafoveal or with the center involving diabetic macular edema, patients who do not have a good and long-lasting results when are treated with intravitreal injections or who refuse intravitreal injections. Also, it can be delivered easily in a pregnant patient. We should also consider this population, or patients who are not suitable for intravitreal injections. Thank you very much.
Well, good morning, everyone. Thank you for being here. Okay, so I'm going to talk about small work I did last year using my MicroPulse laser. Let's talk about TXCELL-GUIDED MicroPulse laser as a safe and effective and immediate care for CSR patients. So the purpose of this work was to evaluate the clinical and anatomical outcomes of patients with chronic CSR diagnosed, treated with my MicroPulse yellow laser. I decided to change a bit, so I did, after I was invited, a little data recollection of acute patients, and I did a small control group because, as you know, CSR is an auto-limited disease. So what's actually the benefit of using a laser in something that usually resolves alone? So what I did was a retrospective data collection at the Clínica Carriazo, where I work in Barranquilla. All patients that visited the vitreoretinal department from January to October 2016. These were my inclusion criteria. Of course, the use of the IRIDEX laser is like the most important one. And we measured vascular visual acuity, central macular thickness, and the thickest macular point prior to the laser and 4 weeks after the laser therapy. These were basic results. This is a demographics, a mean age 54 years, male predominantly, and this is our visual acuity results. We had a recovery of a mean 2.1 lines in a patient 4 weeks after the laser therapy. We can see as a result of the basic treatment, we have 87% of patients that were between 2020 and 2040, and we had a couple of patients that ended up between 2050 or 28-year worst. In the macular thickness, we had a recovery of 97 microns after a 347 mean initial central macular thickness. Recovery of the thickness of the retina, and we had a decrease of 96 microns on the thickest macular point. So we had an 80% of resolution after the laser, and we did have to retreat in 13% of our patients. This is a couple of cases. We have a male patient, 24 vision. This is, as you can see, a CSR. 4 weeks after the laser therapy, we can see a complete resolution with a 20/25 vision. This our second case, another patient, 20/50 vision prior laser. 4 weeks after 20/25, we had still a bit, as you can see here, a small amount of subretinal fluid, but the patient was very happy at the final consultation. What about a control group? It's really not easy to find a control group after you start doing laser because you just forget about not doing it. Or at least that happened to me. So I had to go even backward to 2013, 2014, and I found a small group of patients. We had resolution in 67% 33% of our patients, and we had a small increase in visual acuity after month 4. Why month 4? Because that was my cohort in the first part. In the control group, we can see that the initial thickness of the macula, it was 335 microns, and we had a very small decrease, just 14 microns. As you can see, in chronic CSR, it's just the same if you do or not. And in acute CSR, it's where things change. Again, why doing it? The fact that you usually don't have anything to offer a patient within a CSR, it's very important for my patients. I mean, when you have a 43-year-old male that's currently stressed, and he comes with a decrease on his visual acuity, and you said, no, let's wait a couple of months. He usually doesn't like it. And being honest, the fact that you can offer him something, it's like the plus side of really having it. In acute CSR, we had a really small decrease on the central macular thickness, just 47 microns, but still we had a relatively better results than just waiting 2 months with a 27 micron decrease on the central macular thickness. And when we see visual acuity pre-laser, we had 0.4 in decimal, that's about 2060, 2080, versus a 2025 mean visual acuity after the laser 4 weeks after. And in the control group, we had a 2030, 2040 final vision. So results of week 4, you can see we had a complete resolution in 81% of the patients versus a 75% of our patients. That's not that far apart, but still. And we usually, well, we can conclude the results are very comparable with a lot of studies. What I did was very compatible with the papers that are already written in CSR. We had more than a 70% resolution. We had a very significant decrease in the macular thickness with no evident changes on the RPE. The clinical and anatomical results speaks for themselves. Even in cases who were treated priorly with other lasers, we had no damage on the RPE, we had no retinal damage, and we do consider micropulse retinal therapy as a useful and safe treatment in patients with acute and chronic CSR. But I do believe that we have to do more. And again, why you do it in acute CSR? Because it's the best, for me, the safest, and the quickest option I have. And when you have a patient that's really stressed, why should we wait? This is our TXCELL treatment. As you can see in the video down here, you have no permanent scarring. You cannot see the spot once you shoot at it. This is my parameters. These are my parameters. My spot size is 200 microns. I use the focal grid. The power depends on many patients. We do, or at least I do, t-test where I just personalize every treatment depending on the initial scar. I do a continuous wave spot outside the macula, and when I find a visible scar, I take that power, I pass my micropulse to a 5% duty cycle, multiply it by 4, and that's my power. So I usually do between 360 to 400, 400 something. I deliver a 7 times 7 grid, no space between, so I have a very high density treatment. And when I do acute CSR, I just go to the leakage point, and when I'm doing chronic, I do the leakage point and the whole compromised area. The fact that we can do this grid, as you can see, really facilitates the whole work. But more importantly, I think the physician expectations are very, very considerable here. You have no visual tissue change during any time of the treatment or after the treatment. Usually at the beginning we undertreat. I have to be honest, the first patient I did CSR didn't have any changes. I think I did like 50% of the power I had to do, and I just was really afraid of just going through the fovea. The low intensity, high density applications lead to the quality of results. We have to have patience because, as Dr. Marco and Dr. Estela told, the results are slower than what we want. It can be safely repeated. Patients have no discomfort compared with the intraocular injections, and the fact that you don't have to put anything in their eye is just a plus here. We can see a subjective improvement of the vision, even though we don't have our complete resolution of the swelling of the macula or the edema, and we can treat mild edema in an early fashion. Thank you very much.